To the Department of Geriatric Medicine and Ram. Before I introduce our speaker, I want to do some housekeeping. This CME activity is jointly provided by the Queen's Medical Center and the UH Jabson Department of Geriatric Medicine. At this time, please enter the name and credentials of everyone viewing grand rounds for CME attendance purposes. As a reminder, evaluations are required for CME. At the end of this presentation, we will put an evaluation link in the chat box, or you can find the evaluation link on our website and our email advertisement. Your comments are very important to the planning committee and will be used to plan future programs. It's my great pleasure to welcome our guest speaker, Teepa Snow. She is one of the world's leading advocates and educators for anyone living with dementia or other forms of brain change. She's an occupational therapist by trade with over 40 years of rich and varied clinical and academic experience. Her philosophy is reflective of her education, work experience, medical research, and first-hand caregiving experiences. Her advocacy efforts led to her development of the GEMS state model for understanding the progression of dementia and changes in abilities. She also created the positive approach to care training strategies, which are effective techniques for anyone seeking to optimize care and support for those living with brain change. As the Education Director of Eastern North Carolina's Alzheimer's Association, she also helped to create the nation's award-winning DVD entitled Accepting the Challenge, Providing the Best Care for People with Dementia. Her user-friendly approaches provide guidance and leadership to national efforts to promote best practices in care. Please welcome Teepa Snow.
It's always good to visit Hawaii and to be with folks out this way. You guys have that aloha spirit that I love. I'm from West Virginia originally and North Carolina now, and come on down. We'd be happy to feed you too. And I'm just sorry those of you out there aren't in the room because they brought goodies for everyone. So today we're looking at the issue of dementia screening and assessment and what are options and what are the value of some of those options. And we're also going to explore a little bit of the difference between dementia, delirium, depression, and anxiety, all of which like to hang out together. So go ahead and get your hand out because I'm going to give you a quick cheat sheet. Okay, so I want you to use your thumb, your index, and your middle finger. These are the fingers of skill on a human hand. They're innervated by the median nerve, which runs through the carpal tunnel up into the brachial plexus from the sensory-motor cortex. So if you get your skill fingers out on each hand, these are called also your manipulators. Go ahead and button buttons, zip a zipper, pick up your pen to write, put a nut on a bolt, take it off, put a paper clip on. Everything we do with skill, we use these fingers for, okay? These two fingers over here, your ulnar nerve distribution, which is that nerve that runs down here but goes behind your elbow. If you've ever hit it, you know where that is. These two fingers are not a skill. So for just a second, try to imagine what you're going to do with those two fingers. What can you do with those two fingers on your hand? What do they do for you? You can use it. You know, you can do this exercise, but what they're really there for, which people don't think about, is strength. So when you pull those two fingers in with the other fingers, you now have a power grip and you can hold on to something really tight. So these give you strength. These offer skill. Every form of dementia that we know about, and there's a huge number of dementias. We know, I think internationally representing currently, we think over 120 forms, causes, and types. Every single one of them will rob you of skill before it takes away your strength. And all areas of function. So you will lose the skill of a function before you lose the strength of a function. And so you will be strong, but you won't be skillful anymore. So it's really important to recognize I don't lose everything at once. It's a process. And what I'll have left will be more strong rather than skill. Whether it's visual skills, auditory processing skills, speech production skills, motor skills, reasoning skills, or anything else. So in our screening and assessment, we should be doing this evaluation of what's the skill level and what's the strength level. And when we start losing strength, we should be going, uh-oh, I think we're getting to the end of life with dementia because now we're losing strength. If we're losing strength earlier than that, we should be curious, because that's not being brought on by the dementia. That's going to be brought on by something else. And it could be lack of opportunity. It could be fear and distress or anxiety or depression or a delirium. But dementia in and of itself, only at the very end of a dementia will we see a loss of strength. So right off, that may really change how we think about our screening and assessment. Because what it means is we cannot be effective in screening and assessment. Do this with your hand, do this, unless we know what your baseline is. If we do not have a baseline on you in all these areas, this is bullshit. Yes, I said it out loud. It's bullshit. We're just talking bull. If we don't know what your baseline is, then how do we know if you're changing? How do we know how much skill you're losing, if you are losing skill, and whether or not we're all to the place where you're losing strength? And we've got to look at that. So get your 3 fingers out again. What fingers are these? Skill. So here we go. Do this. Just delirium. It pops up quick. It's going to pop up quick, and you better figure it out quick, or you can actually lose somebody. Delirium. Do this. You want to investigate deliriums very carefully. But if you don't have a baseline, how are you going to know if what you're looking at is a delirium? It's really difficult. And so often when we come in just like that, it's really hard to tell, is it a delirium or is this something that people just hadn't paid attention to? Okay, so this is your delirium, and you could pop it out, because you want to think about delirium. It's popping up fast. We're talking about relatively short range, like hours, days at most, maybe a week or 2 at most. But if it's lasting longer than that, we gotta, I don't know. But a delirium pops up fast. Now, do this one. Anxiety or depression? Anxiety? Yeah, it's going way up. Depression, way down. So it's an emotional state. And so when I see these fluctuations in emotional state and energy state and desire to live state and figuring out how to live state, and I'm having trouble with skill, but it's been I have a pattern of it, and what you're seeing is an escalation of a pattern. So all of a sudden, instead of being a little irritated and a little frustrated, I'm furious, and this is stupid. I'm not going to do this anymore. I hate this. I hate all of you. Let go of me. It's like, wow. So look at it again and go, okay, so how much of it is delirium in an acute episode of something, and how much of it is an underlying anxiety that's been there, and it pops up, but it pops up episodically. Okay, so anxieties often come in episodes, often in a day or over a week. People who are anxious, people who have anxiety disorders, it comes in patterns. I mean, it's not like it's a steady state anxiety. Very few people stay anxious all the time. It comes in waves. They notice something missing. They're oh God. Now, this does get tricky. Do we have anxiety or we have depression? We can look at that. It could be situational. It could be, sometimes it's environmental, sometimes it's chemical, sometimes it's just emotional, and sometimes it's more than that. Now we get our third one. Everybody pop this baby up by itself. Nobody likes it. Nobody wants to talk about it. It's called dementia. But it's actually just a loss of skill set and changes due to neurodegeneration. And one of the tricky parts is, do this, people who live with dementia are going to have episodes of anxiety and depression at pretty significant rates. What we know is people who have a history of anxiety or depression also are at higher risk for developing dementias at younger ages. It's estimated right now, put these two together, that post-pandemic, somewhere close to 70 to 80% of everybody with dementia is experiencing at least one significant anxiety episode a week. At least one. And here's the bad news, do this. It's not just the person who's actively living with dementia in their brain, it's their partner who's trying to support them. So we have seen more anxiety disorders coming out of care partners trying to support somebody living with dementia, and we are all too rarely getting a baseline on anxiety and depression for the care partner when we first see the person living with dementia and monitoring it thereafter. We wait too long to notice this one, the partner having anxiety or depression, because what we know is those, what did I say about anxiety and depression at risk of developing dementia early? Increases it. So what does that say for care partners who are experiencing anxiety and depression? We aren't treating and we aren't supporting them. Turn to the person next to you and say, oh, good, another person to work with who has dementia. That's what I've been looking forward to. I didn't have enough in my list of people to work with. And if they were the care partner, all too often do this, they're the only one left. So especially in spouse partnerships or single kid partnerships. And now they've used up a lot of resources. And now they need support and help. So it's really critical that we're doing better at this assessment and screening than we are. And I'm not looking just at the people in this room, I'm looking internationally. We are not noticing this stuff nearly as soon as we should. And yes, honestly, we are not establishing reasonable baselines to work from. We don't have anything to work from. We do not know what cognitive baselines are, what functional baselines are, what skill baselines people have walking in. So how are we going to notice if there's a change? Well, it turns out we make bad choices on this, and we should be doing so much better than we are, but we're about 25 years behind where we should be. So get your dementia out again and realize dementia and delirium also hang out a lot together. And at some point, do this. You're going to have to decide which you're going to put the energy into. Dealing with, this is the late state of a dementia, and I'm not going to keep treating every delirium. Because the UTIs, got to get to a place where we say, what's the point of treating it again? The upper respiratory, where we've got aspiration pneumonia for the 6th time in 3 months. Why are we doing this again? Because it's failure to have enough skill in cough, swallow, breathe. A primary function of the brain. We should be screening for how well does somebody do. Go ahead, take a glass. Go, 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 go on a regular basis. Oh, what did you do? Do that. Go ahead, do that. Put your, I know you. I should be checking how good is your cough. If you drink fluids, how good is your responsive cough? That serial swallowing, it is a really good quick screen. And every time I see you, unless you're already at risk and I've already identified you, I should be looking to see what's going on, because over time, guess what I will lose with my dementia? That fine motor skill of managing the very complex issue of suck, swallow, breathe. And I'm not a baby. My airway is not protected like babies' airways are because of the structural variation. I actually, anytime I pick my head, that was a nice solid elimination. But if I'm doing that in public places, my skill of social behavior and knowing how to manage secretions, should we be looking at how much milk protein is going in? Because I don't know what you think about milk in your mouth with saliva. But it gets really ropey. How's it starting to break down that protein? Hey, baby. So I'm playing with this a little bit, but we miss so many opportunities to screen and assess, and then we're surprised when we hear that somebody's starting to have problems. But it's because we're not really necessarily thinking about monitoring some of the indicators of loss of skill. And do they still have strength? Are they losing both skill and strength? Because ultimately, for some people, about a quarter of all deaths will ultimately be due to aspiration, which is silent because I'm not reacting to it. as opposed to so that's sort of a late state, but let's go back and let's think about the beginning. So what do we have?
Delirium.
Delirium. Then we have
Anxiety.
or depression or combination, because people have both. And then we have everybody's favorite, dementia. So when we look at these three, it's really vital that typically we need to not just think in isolation, because they aren't. It's really going to take a significant amount of skill to sort out what is it this time? What is it with this human being? What is it in this moment? Is it mostly a delirium? Is it mostly anxiety or depression? Or is it mostly the dementia? And what are the other factors? And what can we do short-term, mid-range, and long-term about these issues if we're looking at a combo? So one of the things that I think we need to talk about is how often do we talk about what's true about dementias? What's true about neurodegeneration? What we need to be thinking, at least 2 parts of the brain are actively dying. That's the rule. At least 2 parts. And as the dementia progresses, we'll see more and more parts get involved in this. The second is that it is chronic. We do not have currently a way to fix this. So when we're in this zone, we don't have a fix for it. But what we can do is look around and see what skills do they still have left, what strengths they have, and how do we compensate to make life livable. We also know that it's progressive. So in our screening and our assessment, we've got to build in multi-points of check. And we'll talk about one of the biggest fallacies, and it is that the MMSE is going to work. The Folstein is going to work after the first time you get it, because it won't. It will never work the same again for most people living with dementia, because they're not friggin' stupid. They have dementia. So turn to the person next to you and say, I have a tool. If you fail this test, you're going to get put somewhere. Go ahead and say it. I mean, I have this 30-question test, and if you do not do well on this, we will be taking away your privileges, we will be changing your life, we will make things happen. Now, let me tell you something. Do this. When you do that, the amygdala, go ahead and pull it out. Your amygdala and your reticular activating system just got a really strong message. Do this. Learn and remember this shit. You better learn and remember some of this stuff, because I'm going to tell you, if you don't hold on to it, you'll get caught. So what starts happening is people start learning the test, and they will do their damnedest to pass. On the way in to see you the next time, in the car with their spouse or with the significant other, go, what's today? Because she's going to ask, what's the name of this place? Because they always ask the name of this place. What were those 3 things? I remember ball, but I can't remember the other one. What were the others? Do you remember? And people living with dementia tell me all the time, I learned that test. Why? Because I don't want to look stupid. So people living with dementia, actually, their brain works for them to give them everything it can to perform well. So what we do know is eventually it's going to kill you. Here's the other truths, though, that I think we don't talk about, and we should. And we should be finding out, what do our people know about this? What do the people who are living with dementia know about dementia? What do they know about neurodegeneration? They only know what grandma experienced when they saw her at the nursing home. Do they only know about Alzheimer's? Do they only know about end state? What do they know? What don't they know about this condition that they're living with? And what do you know about? We should be more curious. What do we know? And what do they know? Tell me a little bit of how you're doing. Are you doing here, here, or here? So go ahead and try that with your partner. How are you doing? Here, here, or here? How are you doing? And keep looking at them until they give you an answer. Okay, so if they go in here, that's pretty normal. It means probably they're somewhere in mid-range. So if they do this, what do you already know you should be looking for? This one. I should be looking for dementia or depression, excuse me. So all of a sudden with one question, so how you've been doing? Here, here, or here? I'm starting to screen for the possibility of depression or anxiety, or that at least I'm recognizing something in my life is changing. And then I will say, okay, so I'm curious, do this. Tell me two things that, even though it's sort of like in here, they're going okay. Tell me two things that are going okay from your point of view. Go ahead and do it with each other. See what you come up with. Try to be honest with each other. I mean, nobody's keeping track. Let's see what happens. What are two things that are going on? I'm here. Family member here. Some of you are here. Okay. All right. Did you guys come up with two? If you were really good at this, you'd be assessing language skills, reasoning skills, ability to stay on track for two activities, and you would have kept track, and you would say, so what I hear you saying is this and this. And you're finding out, do they have social connection? Are they aware of how they're feeling? Do they actually give you some information? And I can do this with people, and as I do this, I start to learn what is their brain, how different parts, how's their left temporal working? What's the rhythm of language sounding like? Are they turn taking? Are they sharing? Are they, well, I'm doing okay. You're doing okay. I use a reflection. You're doing okay. Tell me more about that. You're doing okay. What are two things that are going okay? Well, you know, it's this and that. Ah, this and that. This and that. So at home or somewhere else? Well, you know, there and other where. Ah, so things are going okay here, there, and other where, huh? And they smile and laugh like you just did, or they go, oh yeah. I just learned a whole lot about brain function. And it's an opportunity. I can use these little opportunities to start building a picture of function. And if I don't do this regularly, I don't know what I'm missing. Okay, so now we did, what are two things that are going pretty well? I usually jot those down. And if they can't come up with any, we need to really seriously dig into what? Depression. And if that language was the way it was, I'm thinking, whoa, I really know what their baseline on language is. Are they English speaking? I mean, am I, what's going on here? They have a hearing issue. I've got to really look out. Why is that language so limited? Oh, they used to teach at University of Hawaii. I'm concerned. I mean, even if I know that about them and I know that that's the language I'm getting, that doesn't match. So that's a lot of change. So now I want to know, has it been a while and gradual, or is it episodic, or is this something brand new popping up? But now I have a lot more data than I had before. Now, two things that are going well or okay. Now do this. What's one you wish were different? What's one thing you wish were different in your life? So go ahead and do that. What's one thing you wish were different? In your life.
I'm ready.
Or you can vary it and say, what's one thing you want to work on? Because what should I be trying to identify with my patient, my client? What's their agenda? What's their goal? What might they be interested in? Because if I don't know what they're interested in, it will surprise me when they say, I really want to go home. Because if you don't hear that, you'll miss that they're going to be a high elopement risk if you put them somewhere. And they don't think that's home. If they also have either a delirium, anxiety, not depression so much, but anxiety or dementia. Because I'm just gathering data. I want some data. So, oh, that's not going to do me good. So here are the new things that I think we don't talk about. Things do not work the way they used to. Your abilities are changing. Tell me about that. So if things are changing, talk to me about the changes. What's changing for you? And they'll say, well, I'm fine, nothing. Then I want to turn to the care partner and say, so Dorothy, what's changing for your mom? Only it has to be in a space where I'm not outing Dorothy's mom in front of, and Dorothy in front of her mom. So Dorothy, what's changing up here?
She's getting up so many times a night.
She's getting up a lot at night.
She's getting up a lot at night.
Okay, and when she gets up?
Sometimes like every 20 minutes.
Wow, every 20 minutes. How long has that been going on?
Well,
Like a
No,
month,
No, just
weeks?
like the last few days.
Last few days. Okay, when she gets, okay, so what do I got again? Yeah, so what's changed? We don't ask what's changed. We ask, what are you here for? Not what's changed. It would be so much better for us to assert what has changed, because what we know is time frame matters. And we're assessment of a delirium, a depression, anxiety, or dementia. So Dorothy, now she's up every 20 minutes. Tell me about, so has she been getting up just not that frequently, but a lot at night, or is this totally different?
No, it used to just be once or twice a night.
Once or twice
She
a
could go to the bathroom on her own.
Okay.
Now, it's not just the bathroom. She like thinks, someone's coming to pick her up, or she thinks it's
Okay.
like time to go to the doctor, but that's not till next week.
It's not till
I
next
keep
week.
telling
So
her-
she gets confused about time, it sounds like,
Yes.
and she has an event and it's in the future, but
Yes.
she thinks it's
Yes,
soon.
yes.
So time awareness, passage of time stuff.
I put a calendar up, I
Uh-huh.
write it so she can see it.
Yep.
but She's just not.
She's not holding on to it. Yeah. And how would you say her emotion is when she gets up at night? Is it like eeks or what kind of emotion she's showing?
She's just very confused but she's very focused.
Very focused, so
That she
confused,
has
but
to go
focused.
now.
She has to go now, but not to the bathroom.
Well, maybe once it's the bathroom. but
Once
then
in the
there's
bathroom.
I have
So
to go
she,
somewhere
does she
now.
go when she goes to the bathroom? So this is giving me avenues to explore. So am I looking at a UTI? Am I looking at sepsis? Am I looking at, okay, I'm also thinking, could it be Lewy body dementia? I mean, up at night, but this is new. This is relatively new. Now I still got to do some more exploring. Is she anxious about going to the doctors? It could be this anxiety thing because going to the doctor makes her anxious. And so she's, do this. Her hippocampal area is bringing the time frame, like, we're going soon. It's like next week. But in her mind, the doctor is a real big, hairy deal. And so getting really worried about the time. We don't know if we don't explore. So being curious. Now, if we think it's delirium, you guys are really good at delirium because of this training you've got more training in recognizing delirium than anything else, generally, most people. So we're looking at, is it possible pain or discomfort? We also want to look at behavioral histories. Have we seen a change in behaviors? We're wanting to look for the potential of infections, obviously, any med changes or side effects from meds or interactions of meds. We also want to look for the physiological issues, and these often get missed most frequently when there's that underlay of, I'm not saying screw you, I'm saying dementia. Of the thing nobody likes to look at or think about, underlay of dementia increases the risk of dehydration and impactions and problems with input-output systems, electrolyte imbalances, problems with med management. If I have dementia on board, there's a higher probability I'm going to have episodes of delirium secondary to mistakes in skill. I'm losing skill. I'm losing skill to manage time. I'm losing skill to manage life. I'm losing skill to manage relationships. I'm losing skill in managing me. What we also will notice is that people who are living with dementia will often start experiencing emotional pain. And the emotional pain will be expressed in one of 5 ways. So get your fist out, because I believe in 5, the power of 5, because you hold on to 5 things. Yeah, 5 digits for a reason. I said, take your thumb and put it on the outside and say, you go to hell. This is ridiculous. I want the hell out of here. And you'll see that often with a delirium, but you can also see it with dementia. You will also see it with anxiety or depression, but this is anger. So you'll see me being frustrated and angry, and it can escalate all up to infuriating. Then we have the second one. Take your finger and do this, so you remember it. What's this? I'm sad. I'm blue. I'm sad. I'm hopeless. This is hopeless. This is hopeless. I can't do this anymore. So hopeless is the extreme. What was the extreme over here on anger? Infuriating. And you don't want to get all the way up there, because if you go all the way up there, it's so much harder to bring it back down. So the sooner I can notice anger or frustration, the sooner I notice sad or blue, I want to do something about it and not let it escalate all the way up. And if it's all the way up, I have to go back to, could there be a delirium on top of a depression or anxiety that we were sort of managing and it's getting out of management because I also had a undiagnosed, untreated depression. Third one, do this all by itself and say to the person next to you, I'm trapped. I feel like I don't have options. I feel like I have to do something. I feel that I'm, you know, everybody has these expectations of me. I've got to do stuff. I feel imprisoned. I'm trapped. Or this, I've been left on my own. So the same finger is a whole other side. I'm all alone. I am isolated. I have been abandoned. There is no one, no one cares. No one cares at all. Do these two like to hang out together. I go sad and abandoned, but I'll be angry at being trapped. These guys like to partner up. It's a party. Now we go over here. Do this. Oh no, please no. Oh, whoa, what's going on? I don't understand. Wait. Scared? Oh God, no, please don't do that. Oh, what are you doing? Don't, no. Oh my God, terrified. I was known as panicked. Absolutely terrified. And then this last one. I must find value in living. There's got to be purpose. I am so friggin' bored. There's nothing to do. There is absolutely nothing worth doing. I'm not doing it. This is crazy. I just want to take me back home. I mean, you know, this, please. This is absurd. I don't want to be a burden. I'm not, just, I have no purpose. I feel purposeless and bad. So those are the emotions that you might want to pay attention to. And you might want to notice and sort of look for. Because those levels of emotional distress are often covering. And so if you look for them, you might notice them, but what they might be covering for some people is the underlying neurodegeneration, the underlying the physiological changes that are going on. But you'll see the emotions, and we don't want to get tricked by the emotions. We want to be informed by the emotions. And if somebody's had a low level, this is why you have to know baseline. If there's been a low level and it's escalating, our brain should go, okay, so what's changing? Okay, now I'll give you another 5. Here's your other 5 to make it easy. Ready? Are they in a different place, or is the place changing? It is people. Are there different people, or are they losing people? Are people changing on them? Are the people behaving differently? What's going on with the people in the place? Ooh, this thing. Props. What kind of things are available to people? The things that we do with stuff. Stuff. There are stuff in our world that makes life, like what's in front of you right now? What do you got? You got a phone, you've got drinks, you've got paper, you've got a pen, you've got a chair, you've got a table. And if I change that out on you, it's not yours, or your brain doesn't recognize it as yours. Those aren't my glasses. These aren't my teeth. I don't know how to get my teeth in my mouth. I don't know the stuff that how do you make this thing do something? The controller. I don't know how to use the controller. So the props aren't working for me. We want to really look at the props around someone and recognize in that place, in this situation with those people, is the person being comfortable skill-wise. Because the next one is programming. How do I fill my day? Do I have things in my day that give me value and purpose? Do I have things in my day that give me pleasure and satisfaction? Do I have things in my day that are good for my body and my brain? And do I have things in my day that allow me to rest and restore? In Dorothy's situation, what's her mom not doing? Resting and restoring. So who else is not getting rest and restoration? Dorothy. And so this idea of, and this last one, your last P, these 5 Ps, what are the possibilities for change? And what are the possibilities that something has changed? So by looking at these and we put that together, we can start to come up with a game plan. Because if we're not going to screen and do something with it, if we're not going to do something with our assessment, why do we bother with the assessment? So we want this data so we can make some shifts. So yeah, we know about delirium. I know you guys are very common, you got it. We've got to talk about anxiety and depression for people living with dementia. And so I'm going to give you an example of somebody who's pretty late in their dementia. Okay, so I'm going to be real late.
Hey, Tifa. Hey,
Let me help you. Give me Okay, so talk to somebody about what you just observed and what's your screening assessment of me.
What's going on?
And I can already tell you in the chart, she became agitated and aggressive. It came out of nowhere. She hit Dorothy, yes. But what's your screening? What's it sound like? What are you noticing about me? Okay, so here's my first question. Was I looking at something? I didn't ask you what I was looking at. I said, was I looking at something?
Yes.
Yeah. I was looking at something. Did anybody make an effort to figure out what I was looking at? Did you make a lot of assumptions about what I was looking at? Who else made an assumption about my visual regard? Dorothy, she interrupted it thinking it would be fine. And she totally missed that that wasn't fine, even when I gave her a signal that it wasn't fine. She ignored me.
Hey, you did it now. You got it now.
Yeah.
That's a month. Yeah, you got it. That's a nice one. Thank you. Thank you. Yeah, okay.
So pause for a second. What do you now know?
Love shoes.
Do I think it's necessarily a shoe? Am I interested in it?
Yes.
What did Dorothy do that was screening, assessment, and intervention all rolled into one? She did. She offered several alternatives. Was I interested in any, was I interested in a person?
No.
Was I interested in changing a place?
No.
What did I want?
You want
A prop. I wanted this prop. I was fascinated by this prop. And what I did with it when I got it, what's my program?
Keep it.
I want to keep it. I'm really curious about it. Now, by allowing me to have it and making this assessment, what was eliminated? What didn't happen?
You didn't
I didn't hit her. It didn't escalate. I didn't become infuriated with her. I didn't trap Dorothy. So all of those things didn't happen because I got my value and my purpose satisfied. Now, you look at this and what are you thinking? I can tell. I can see it in your eyes. I know you're judging. I know you're judging me, but when you're judging me, are you thinking, okay, so do this. I will bet that at best your visual gaze is something like this. She can take in about 18 inches of data at a time. When she looks at objects, she doesn't recognize objects for use. So boy, in her environment, we're going to have all kinds of issues with what she tries. And when she gets it, did she show skill?
No.
What did she show? Strength. What kind of strength did she have? Really good strength. Do you want to acknowledge that strength? Because will you have to acknowledge it when I attack Dorothy? And will you write me up for it? And will you try to take it away from me with drugs? Instead of figuring out, why did I do it? Why did I hurt Dorothy? Because she infuriated me. How much is my dementia and how much is a delirium? You don't know unless you have a baseline. But if your baseline is Tifa is agitated and aggressive, That's my new baseline. And from now on, all we're trying to do is manage my agitation and my aggression, rather than trying to figure out what is Tifa interested in the world. So she gets really interested in picking things up, things that have a contrast in the back. Things, what do you notice about this shoe? Black. It's dark. What else do you notice about it? It has texture. Guess what I'm doing with it? Do I seem to be fascinated with what I can see and what I can touch? Do I want it?
No.
Oh, yeah. So this is where we start to really start in thinking about watching me, learning about me, but rather than sitting in judgment of me, try some things to figure out what it is you can get me to interact with you on. So when we're doing this work, all too often, I think what happens is with people living with age, increasing age, or people who have multiple health conditions going on, I think we have a combination. And I think all too quickly, what we want to do is identify the one thing that we're going to do. And what I'm going to tell you is you got to quit thinking that way, because it'll just wear you out and you'll be chasing around in circles. And what we want to think about is, okay, so if we have depression, and it could be the very first time in my late life that I've ever been identified as having depression or anxiety, turn to the person next to you and say, people like me don't get depression. That's for really weak people who don't know any better. These are whiners. These are people who just don't pull themselves up by their bootstraps. These are people who we take, there is nothing wrong with a few glasses of wine in the evenings or a martini to calm down after a hard day at work. Stopping by the bar is just what you should do. Because what we know, in fact, is the current generation that we're trying to help and often support are not used to seeking mental health assistance. It was so common to hide it in the closet because we're scared of talking about this stuff. It's actually uncommon to talk about it, which means the next generation down doesn't have a way of trying to help other than turn to the person next to you and say, Mom, you're depressed. That's what I'm telling you. You're freaking depressed.
Mom.
You've got to take the drugs to go with your baby. This is going to go well.
Yeah.
Tell you what, I'll take them. We also know that there is often a resistance to seeking help in this area. And so what people will do is wait until it's a crisis. And the person who's more likely to bring it up is somebody who's living with the person or around the person than the person themselves. Additionally, what we know is depression and somatic complaints really come in handy. So this sleep problem or problems with pain, those kind of things will often happen. What we know in addition to that is that we do not get accurate diagnoses of dementia until way too late. And when we have an accurate diagnosis of dementia, it allows us to plan the future with greater accuracy. Because if what I know I'm dealing with is a Lewy body dementia or a frontal behavioral variant of a frontal temporal dementia, or I'm dealing with Alzheimer's plus vascular dementia, or I'm dealing mostly with a chronic traumatic encephalopathy, or maybe what I'm dealing with is a posterior cortical atrophy. If I've done a good workup and I know that that's pretty much what I'm looking at, then I can guesstimate progression patterns for that particular condition. And I can look at retained skills, which skills are more likely to be retained longer, and which of these abilities are going to be lost first. Where do the person might have some strengths that we can build on, and where do they not? I think one of the most missed screenings that we have potential to do is for the potential of looking in the prefrontal cortex, put your hand here, at whether or not I can look at myself accurately. Look at yourself and go, skills, talents, abilities, and then go, a few things I'm not so good at. Mostly our perception of ourselves is based on past experience and the input of others and our own experience. But now look at yourself, and now look at the situation you find yourself in at this moment. You have to make a judgment call. Here's the first one. Do this. I'm fine. I can handle this. I think I need help. The ability to be accurate at determining whether I think I'm fine, I can handle this, and in fact, I have the skills needed to handle this, or I'm accurate, I need help. This is way beyond what I can handle. We call it anosognosia when you don't have that skill. Anosognosia, the inability to be self-aware. But we only typically have it, we only say that about people living with dementia. And what I would say is most family care partners frequently don't know they need help until they're drowning. Most professionals don't look for help from experts until they're drowning. They don't come to the ER until they're dying, drowning, having problems. And that's when you see them when this is escalated to such a degree that you're trying to put a Band-Aid and you look underneath and it's like, oh my God, this is so deep, this is so wide, this is so out of control. They come into the hospital for dehydration. Like you uncovered, it's like, this is not just dehydration. Oh my Lord. And this is what we're currently doing is we're waiting until somebody uncovers this because with dementia, there's a lot of anosognosia to go around. But it turns out for people living with dementia, only 50% of them will actually have it. 50% of people living with dementia are actually aware of their condition and the changes sooner than anybody else. The problem is if I'm scared, I want to hide. Because by hiding, I stay safe and maintain status quo. Except with dementia, there is no status quo. So what we do know is that dementia does not equal Alzheimer's. So when we're doing the screening, turn to the person next to you. So tell me what you know about dementia. How many ask your patients, tell me what you know about this thing, neurodegeneration, dementia. Tell me what you know about it. Ask the family, what do you know about dementia? Because if we don't ask that, what's the baseline? We don't know what baseline we work with. So how have you been doing? And tell me a little bit about what you know about the brain changes that come with dementia, the life changes that come with dementia. What do you know? Because if they don't know, we've got to figure out where we're starting. And our biggest challenge is we never check the baseline. We make assumptions and they make assumptions. So under this umbrella, we've got a whole host of things. And on the next page, which is part of the PowerPoint, we have some very basic ideas about what are these different things. I mean, what are different dementias look like? What are some of the core ones? So, do you guys know some of this stuff? So I will pull the card out with people and say, so like dementia is a great big umbrella term. And there are a lot of things under it. We aren't sure exactly yet which one we're looking at here, but probably it's looking more and more like we've got something like this going on. So I'm going to give you the back of the card because I'm curious if you've noticed any of these symptoms at all. Because what it is to this is called empowering people. We've got to use their strength and we've got to figure out what skills they have. But if we don't do baseline measures, we're missing the boat. And I think all too often we're missing the boat. That's just being brutally honest. And I'm putting myself in the category as well. Our oldest screening tool was we waited until they died and we looked at their autopsy results. It's like, wait a minute, I think that's a little late. And then we would wait until we could do x-rays and we were looking for broken things. So when we do somebody falls, what we're looking for is the fracture. What we're missing frequently, if we just look at the fracture, is the potential for a bleed out that will eventually result in somebody's death. If we, oh, good, we turn to the person next to you. It looks like she didn't break anything. Yeah, she's gonna be bruised. She's gonna look like a raccoon for several days because what we noticed is when she fell, she didn't even turn out of the fall. So do this. She's lost the strength and the skill of protective extension. She doesn't even throw it. Body part out, she doesn't turn her face out of the fall. Wow, I have a very, very slow reaction time. I have no ability to protect my core. Wow. So if that's the case, and I did this face plant, I should be looking at, wonder how much, take your hand, put it inside your skull, and put it right up there, fit it in real tight, and then fall forward. And the skull is gonna protect your brain. And now, pull the brain back. So you have about maybe half an inch, maybe 3/4 of an inch even because of the atrophy. And fill that space with a fluid, cerebrospinal fluid, not the consistency of water. And now anchor the brain at the back with a spinal cord in the medulla oblongata. And now fall on the floor and boing, 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 boing. And what's on the outside there? Just as a quick reminder, blood vessels. And so we look at this stuff. What I would say is right now, I think the one that we do the least that we could do more with is the clinical interaction. Quite honestly, we could do more, but we count on some of these things to help us out. And we miss some of the opportunities we have to get really basic data and understand what to do with it. So the old one, the MMSE, over time, it's been demonstrated, it is not going to identify people in early stage dementia. It has too low a ceiling and too high a, it's really good at identifying people's educational backgrounds and their cultural background. If that's what you're looking for, go for it. Other than that, quit using it. Quite honestly, it's a waste of time. It shouldn't be used. And it never was a gold standard. That's the frustrating part. Here's some of your newer things, the AD8, that's been around for a while and it's still too limited, but at least it starts asking questions about change. Another one is animal fluency. I really love animal fluency because I can keep it going long after they can come up with the animals on their own. I can show pictures. And then I can ask the question, which one's a cow? Which one's a this? So I'm still figuring out what are their strengths, even when they lost a lot of skills. So animal fluency, I like that one a lot. Clock drawing is going to be out of date before very long. Nobody uses a regular clock. Young people don't even know what I'm talking about when I say clockwise. It's around, it has value for right now, but it's going. It's going the way of the dodo. We've got to find some other things. Instead, I use trail making. And I use trail making because it helps me look at the ability of the brain to switch focus and stay focused. So it allows me to really look at a number of things in a fine motor skill set. I also tend to use the slums if I have to. The other one that people will use is the sage or the mocha. And the plus of all these is they have variables. And so you can do a variation on the slums, a variation on the sage, and a variation on the mocha, so you're not getting the same exact test. You can also do the full workup. The AD8, if you're unfamiliar with it, it's looking for change scores. So it asks these questions. Does your family member have problems with judgment? Do they show less interest in hobbies or activities? Do they repeat the same things over and over? Do they have trouble learning how to use a tool, appliance, or gadget, etc.? So they have those questions. I think what we're missing, however, is self-screen. Are you noticing new problems with judgment? Are you noticing some less interest in? Are you noticing you're having trouble learning how to use a new tool, appliance, or gadget? Because if they self-identify, they're either accurate or they're not, but it gives me a place to start. Animal fluency, clock drawing, slums, rating. Trail making, this is what it looks like. It can also be helpful to figure out whether or not you want to send somebody further on for screening for driving or managing public transportation on their own. Being able to call an Uber safely and get where you're going to go and get back. Because this kind of work, it will also, like if you have visual motor disturbance, it will also start to help you look for that and maybe explore that a little further. Additionally, what I like to do is some practical task performances in what I do. And so I will often purchase things from a list, to go to the store with somebody, give them a list and see how it goes. And let's take a look at how that went. Because if you're going to live independently, you should be able to go do that stuff. Make pudding. And I watch how they do things, and it will either be instant if I don't trust them with a stove, or if they're cooking things at home, can they follow the directions on the container? And can they actually make pudding? Show and explain medications to me. Take off your shoes and socks. I examine your feet and then have you put them back on. Because I want to see how you get to your feet. I want to see what your toes look like. I want to see what your toenails look like. I want to see how well you can get down there and get back up, and whether you're breathing funny when you do it. And then my other favorite I like to do is get up and go. Because even if there is some delirium going on, how much I can get them to interact with me is really important to assess. Because if I focus them, can they do things? That means part of the problem is where we are and what's going on around. And it's amazing how much when you connect with someone, you're actually able to move things forward. So ideally, I think we should be establishing baselines for each other. We should be measuring each other off our baselines. We don't need to go to the doctor for that. So if I were to say to you right now, you have 1 minute, and I'll give you 1 minute, pair up. And I'm going to turn my record on my phone. So this is what I'll do is I actually record you naming as many animals as you can. So that when we get back together again, you can play it, I can play it, we can listen to it, and we can see where you were and where you are. And if I see a quick change in your animal fluency, it's like, whoa, that really changed. If I see a drop. So for me, I know, see, when I said you were going to do it, you jumped up. Okay. If I were to tell you my average animals is 45, and then I were to go do that standard, which I'm over 65, by the way. So I would only need to get 12 to be considered normal.
Oh, dear.
How much of me would I have to lose before we might identify there's something going on with me? Close to 3/4 of capacity. And I don't want you waiting that long to notice I'm having problems. And if I don't know I'm having problems, I hope you're better than that, because I'm counting on you. Because if it's not you, who's it going to be? And if it's a cute episode, I sure hope you figure that out. Because if not, it could be all over before we figure out this is, yeah, she's 72, but she was living independently. And it wasn't because we weren't noticing. I mean, this is something really different for her. So we better figure it out. So we have a huge responsibility. So I'm going to pause there because we could play some more, but the question is, what do you want to do? So questions about the idea of assessment, of screening, and how we currently do it and what we have potential to do if we could let go of some of the preconceived ideas we have about what screening should look like, what assessment should look like. Any thoughts? Yeah.
How do you like to explain trails? Because it's really frustrating.
Yeah, so I
Explain
start with
all
a
the time.
much simpler thing. Yeah, so what I do is I make one that says 1A, 2B, 3C.
That's it.
And I put it on a separate page and I said, this is what we're going to try. I want you to take your finger and we're going to trace. So I'm going to tell you, we're going to go from 1 to A. So go ahead and do that. Okay, now that you're on A, I want you to switch back to numbers. So what comes next? 2. Okay, go ahead and do that. Now you're going to switch. What's the next letter?
B.
Okay, so what's the next number?
3.
Because if they can't do that,
The next.
that's my pre-screen for the screen. Because I don't know when I'm running across somebody capacity, and what I don't want to do this, is expose their inability. I'm looking for what are they able to do. So I'll start with a simpler version to make sure we've got where we're going in the right direction. Because if we think about it, one of the big problems with MMSC, what's the day, what's the date, what's the day of the week, what's the month, what's the season, what's the year, what's the name of this place, what floor are we on, what city, what county, what state. I'm going to give you 3 words to remember. Ball, flag, 22. Or if it's 3 words, say it back. Okay, now have 100. Take away 7. 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 Have you ever done serial 7s without paper in your friggin' life? No. Okay, now I'm going to ask you to repeat something. I mean, like, who wants to start off failing?
Yeah.
Who wants to start off being quizzed on your orientation to time and place in a way that's really quite confrontational? And that's how we started. And we only asked them to remember 3 things. What the hell? They should at least be able to hold on to 5. And we only asked for 3. This is the stupid, why would you do that? And we play, and then we go back and say, well, one of them was a piece of clothing. Maybe you could have started with that. I'm going to ask you to hold on to things. So the first one is a shirt. And the shirt would be in which category? Would you say it's something you wear? Or would you say it's something you eat? Okay, so why didn't I say, what is a shirt? Or do you have a shirt on? Oh, yes. Oh, no. We don't even check yes, no accuracy very carefully. So here, I'll do it, Dorothy, so everybody can see it. So I have you down for a PRN pain medication. Let's try to I have you down for PRN pain medication, okay? Now you understand that you would have to ask for it, right?
Right.
Okay, so let me ask you, are you hurting at all? At all? No? Okay, and you know I'm gonna be tied up down the hall for about 20 minutes. So, but if you need it after that, let me know. Okay?
Okay.
Okay, great. Patient refused PRN, no reported pain. The aide goes in, got to sit down because you're in the bed, and the aide says, okay, let's get up and go to the restroom, okay? Because we took the catheter out. Now we're gonna want Miss Dorothy. Come on, let's get up. Dorothy, don't you? Come on, get up. And Dorothy goes, ah. Patient became agitated and aggressive. She's out of it. So this is where we don't do the screening and the assessment, because what I didn't realize was what? I gave great visual cues of the answer I wanted to hear. I'm not self-aware. We are so unself-aware, because I won't just pick on the nurses. So now, last time you were in, we talked about you were going to stop driving. Did you do that? Okay, and you're taking the medication the way I prescribed it? Excellent, good to know. Have you been having any symptom side effects, anything at all? Any questions for me?
No.
I'll see you in 6 months.
1 minute visit. Just
So
like-
I'm teasing a little bit, but I wish I were, because I'm not sometimes, even without meaning to. We work so hard to connect and communicate. We give them the answers we want to hear. Yeah.
So part of the nice part of having standardized tests like that is it's a quick and dirty way to communicate to other providers.
Yeah.
The baseline of where this patient is cognitively.
Yeah.
So what would be an example of how you would document, because you're not using the test in the standard way, how would you document to the next
The next
provider,
person. Yeah.
what this person's actual baseline is?
I would say unable to initiate or perform animal fluency without supported visual cues. With supported cues, was able to identify 20 out of 20 animals when visually presented. So for me, that's good data, because it means visual data works. Verbal, asking somebody to come up with something on their own, doesn't work. So what does that mean when asking somebody, what would you like for lunch? What are you going to fill out on your menu while you're here in the hospital? So what are you not going to be eating that I would really want you eating? Because you didn't pick what you wanted, and when they brought it, you saw it, and you don't like what you got, so you're just not going to eat it. So I mean, I work with practical data because that's how people live, is practically. So how do we come up with ways to really record and share that which makes a difference in someone's life? At this point, we need to do really assessment to find out how well she is driving. We also need to go ahead and put in place a plan for when she will not be able to drive, which system she would use. Will she use Uber? Will she change residence? Will we be looking at family doing the driving? How is that going to be, how do we make these plans so that we're not dealing with crisis? And we've got to start way sooner than we are. Because when we miss about 70% of dementias until mid-state, we're way too far in the ditch to really bring families back online, because now they're playing catch up. And they're always in crisis then, because we've gone too far too long without anything. And people were just thinking, well, it's getting old, it's depression, it's anxiety, and it's problems with sleep. But what we didn't look for, what's the underlying thing that's really driving stuff? And nobody wants to look. And that's our biggest challenge. Nobody wants to look.
Everyone join me in.
Thank you.
Our online audience, tomorrow is the Queen's Conference, and it is a hybrid conference, some in person and some online. If you haven't already registered, you still have a chance to do so. And Deepa is gonna be our keynote speaker and is gonna give us more insight there.
I'll
Thank
mess
you
with
all
people.
for attending. If you want CME credits, don't forget to follow the link that Michaela put in the chat box and put in your information in order to get CME. That includes the people here, by the way. Please put in your information to
Oh, well, we'll have to get their link.
You'll get your-
You'll get your link. Oh, good. You wouldn't have to set through this and not get a link. That would be good.
Thank you, everybody. Bye-bye.
Thank you.
Thank you, everybody.
You know, this just fills me with ideas and thoughts. I mean, I primarily work in the hospital, but we need a menu with pictures.
Yeah, you sure do.
Besides.
And you
we
need either
finger
or.
food.
Yeah.
I mean, I've been begging for a finger food menu.
Yep.
For years in the hospital for people who have,
Who have trouble
Trouble
with skill and they can't use utensils. You
right.
need to quit putting saran wrap over the crap.
Sorry. Hit those cameras.
It's really hard to get saran wrap off when you
Yeah,
don't
we
even
always
know
have
it's
to
there.
open stuff.
And then you're like, well, never mind. I don't know what's going on with it. Or it's covered.
But if they could
Leave the
just
cover on it.
point
Not
to
help
what
it.
they want, it would be so much nicer.
Yep.
And then
Well, restaurants put in picture that which they want to sell because that's what they figured out. People buy what they see because it's easier to make a decision that I want something when I see what I like. Because I'm trying to judge, what do I see? What will it taste like? What will it feel like in my mouth? What will it smell like? And so if I can see it, at least we've eliminated one mystery. And I'm trying to read words and translate them into tastes and looks, and it's just ridiculous. I can't do it. Yeah, you're right. Yeah. And what we know is too many choices overwhelm somebody. And then they're just, so it's this or this, and then it pops up this or this, and then it pops up this or this. So it's a sequence, because there's actually 8 things that you have to pick with a meal most times. People don't think about that, but we have drink, we have soup or salad, and what kind. Then we have things like main dish, we have sides, we have desserts, and then we might have these extras that we put in there.
Yeah.
Like, okay, now what utensils are you gonna use? What kind of containers for the drink? What about the condiment? I mean, it's really complicated. They do this in the country.
and we have so much trouble with people in the hospital not eating.
But you
Yep.
think
That's
that's
Well, and also when they call them and it's just audio.
It's like super not helpful.
Are there health systems that have that, like an iPad?
There are,
that they
actually,
can
yeah, there are
take
numbers of
with
hospitals.
them?
Most of them are, I would say, probably the niche hospitals. And there's more on the East Coast that I've seen. I think there's one in Wisconsin. There's one up in Boston. There's one in Minnesota. There's another in New York. I can't remember where in New York. But there are some around. And there are some in different countries that are starting to look at visual stuff and different patterns. So, cool. Well, thank you guys.
Thank you so much.
Thank you. Hopefully it was helpful and not just repetitious of stuff you've heard before. Maybe it
No,
was.
it
Awesome.
sparks,
Good, you're welcome. Good. All right. So now we're good till 3:30. 3:30, yeah. Okay. All right. And you guys have, now there's plenty of sugar over here.
For people who have,
Now, did you do your tea?
yes, I did.
Did you do other stuff?
I had a delicious choose.
Did you? Which one did you have?
Oh,
The point.
Yes.
Okay.
It was wonderful.
I don't know. These are my new favorite. And I'm the only one that's had one?
That's great.
These are amazing. You guys aren't eating these? Is that because they're really, really bad for you? And they're like 2,000 calories, right? Like, I think it's accurate. I mean, I don't doubt that. for a second.
I was waiting to see like what the rest of the day was like. But I, okay, I'm just gonna try to fit it in
Hey.
the next hour.
Oh, hi. No, thanks.
Under-
Actually, someone.
She's fine.
Yeah.
So when-
Tried to verbalize.
I don't.
Good.
I go see it, like, yeah.
Oh, yeah.
We have like change there.
Oh, okay, cool.
Yeah.
Very
It's
much.
hard to-
Thank you.
Have you got your dose?
Yeah.
Not today, not today.
Yes, I feel bad for you. Feels like food will hardly be
I
worth
was.
it. That's just so sad.
That is sad.
That's just too bad.
Almost 2 years.
Oh, I also, I did bring, a couple things, that we have. Like, if you do wanna order those prints.
Yeah, there was 3 years on that round.
And everything.
I'm not talking to you.
So, people were just saying,
Yeah, how are you?
seeing what would be behavior.
Not as a. David and then the other guy.
So it was like, I went to the office when these guys were.
What are you?
Sherry for the.
Scott, yeah. Scott is
Do you go to many Dolores care homes?
I don't know, I'm not really good.
Yeah.
What do you know?
So, yeah, so.
I wonder if Jess would know. That was a care home years ago that would, that when I was. As many,
No, that's not Medi, no, Medi, M-E-D-Y.
Go to a Medi.
Okay.
So I've been there, like, I got a.
Right, guys. We like helps you pull it. I did, yeah.
So we're just having a care
Yeah, like
Which other door?
a care home level. Yeah. Yeah. I don't know if you remember. I will try to keep it a little bit. Yeah. She was seeing Gina. Grew up, I thought, with.
No, I don't think so.
Oh,
Yeah.
You just spelled it the same way.
Yeah.
But, we have an agreement with David and Scott, so some of our providers. We store our vaccines. Yeah.
That's why I said.
So I don't know for
A
it's
lot
that
of
big
the
issue
organization,
with
like, told us.
provider, ultimately things, right? And knowing that provider.
So we stand with our agreement, so I just swing by. there. Yeah, but, still.
My mom.
Yeah.
I don't know how she gets so
Very
very.
Okay.